Hi, everybody. I'm back. So we had world travels in August, September, and October, and then we just got back from Chicago. It's totally magic class. It's been a great few months. I missed everybody. Oh, goody, we have 6 people. Okay, so this is the title of this webinar is It's All in the History, and it comes from cases that I've done since we've been on the road, plus just an update on the Vegas at the end, because it turns out that the Vegas is like everywhere and does everything. So let's start out. The theme, if we have one, is It's All in the History. And so this history was a 54-year-old male patient with a history of episodic low back pain going back 15 years. Worked as a laborer in construction. He worked as a janitor. And when they did imaging on his low back, it showed a small disc bulge at L5S1. No other imaging has been done. And his current symptoms, those presenting symptoms, include 3 years of severe right hip, right lateral trunk pain up to the lower ribs, right lateral leg pain, down the foot, down to the foot, up the medial leg, up to the groin, causing what he calls electrical shocks and burning pain at the tip of his penis. That is a weird pain pattern. That is not facets, that is not discs, that is not nerves. So he described his pain as deep, aching, this burning, stinging pain at the end of his penis, worse at night. Had him bend forward, no change in pain. Had him lean back, no change in pain. No change in pain with activity. It was better when he laid down, but it's not worse with bowel movements, sneezing, or coughing. And then no medication helped. Currently taking gabapentin and ibuprofen. They've done prolotherapy, injections, physical therapy. Nothing's produced a change. Surgery for the L5S1 disc being considered because he has leg pain. So let's go back and pain patterns. If it was a disc, it would be worse with bowel movements, sneezing, coughing, and flexion. If it was a facet, it would be worse with extension. And that pain pattern, trunk, hip, started in the hip, trunk, leg, medial leg, up to the penis. Think about that pain pattern. He was pain-free until one day 3 years ago. And I said, when did your pain start? He said, I took a nap. Excuse me? He woke up from a nap with severe hip pain that spread up the trunk, down the leg, up the leg, and then affected the penis 3 to 5 days after onset. He has consulted with general practitioner, physiatrist, PM&R, psychiatry, physical therapy, massage therapy, and acupuncture. Treatments that produced no improvement included prolotherapy, physical therapy, opiates, gabapentin helps a little bit. And here's the piece of history. I asked him if he snored, and he snores when he sleeps. He fell asleep on his back. He fell asleep on his back. So he did a physical exam. Lumbar range of motion was normal, produced no change in pain. SI joint screen, because you could theoretically think that if you had a big, nasty SI joint sprain that you could get pain in your groin and hip. Didn't explain why he would have pain in his trunk. No ligamentous laxity. Patellar reflexes were hyperactive on the right, normal on the left. Ankle jerk on the right, 1 bead of mild clonus. Proprioception, Proprioception at the ankle was hypersensitive on the right, but not on the left. Skin sensation was hyperesthetic on all of the right leg, the right hip, and the trunk up to T8. The skin sensation was normal for sharp on the left. So I'm presenting this physical exam because in 22 years, I've never seen one. It's not like you're going to see this patient in 22 years, it's first 25 years, first time I've ever seen somebody that presented like this. But that's the physical exam. The key is in the history. The key is in the history. What's the mechanism of injury? He woke up from a nap with severe hip pain that spread to his leg, his trunk, and his penis, and the patient snores. Pattern recognition. The pain pattern and physical examination pattern don't match anything I know about from the spine, the disc, the facets, the nerves. The pain is described as electrical and burning. That means it's probably nerve. And since it doesn't match any of the spinal nerves, the only nerve left is the brain. Here was the hypothesis. The patient had a stroke during sleep in either the sensory cortex or the thalamus, causing central or thalamic pain. If stroke was in the sensory cortex, it'd be the first one I ever saw like that because there was no motor loss. He had no spasticity, no weakness. All he had was pain. The stroke occurred, this is my hypothesis, because he has sleep apnea and he snores. So this is the book you read in order to get as convinced as I am that sleep apnea is a fatal condition. William Dement, MD, PhD. It's called The Promise of Sleep. It is transformational. You'll never look at snoring or apnea the same after that. This is the homunculus in both the thalamus and the sensory cortex. But look, the pain pattern matches. The hip, up the trunk, halfway up the trunk, down the leg, to the foot, the toes, up the medial leg, to the penis. Okay? So this is in the sensory cortex, and that's how it's arranged. And this is why your face is so sensitive. I didn't realize that this part, that next to the foot, was the genitals. Who knew? So that's the same homunculus that exists in the thalamus. So the treatment was based on the hypothesis. The hypothesis was based on the history of the physical exam. The pain started when he woke up from a nap. So the point of this is kind of not the treatment. So neck to feet, 40 and 89 for thalamic pain. If you have a thalamic stroke, 40 and 89 is the pain weight. And it did. He was pain-free 30 minutes. Neck, leg, and foot, 81 and 92, and then 40 and 92, just in case it was the sensory cortex, which didn't make any sense to me. And we ran the concussion protocol with a magnetic converter at his waist. The result, trunk pain receded first from a 6 or a 7 down to a 0. Then his hip pain was reduced. The pain in the penis went down last, and it went down to a 0. Patient left pain-free, and the treatment lasted about 60 to 90 minutes. Good portion of that was the history, because I'd never seen anything like this. So the key to this one is it's in the history. So the follow-up was recommended. Repeat treatment as needed. The patient was told that the pain would return in 24 to 48 hours. The patient is very likely a candidate for custom care for home treatment maintenance. For Dr. Wang, I suggested that they order a brain MRI to establish the site of a stroke and order a sleep study and get a CPAP, because remember the lady last year that we treated that had the stroke? She was age 35. I treated her when she was 38. We got rid of her pain, but they had done surgery to get rid of her tonsils and adenoids. And I didn't tell her to get a CPAP. So between the time I treated her last year and the time I got back this year, she had another stroke. So if somebody snores or somebody has sleep apnea, they get a sleep study and a CPAP. Continue gabapentin as needed. Do not do spine surgery, and do not do additional prolotherapy, epidurals, or any other physical medicine, because this is in his vein. Okay, so this next one is post-polio syndrome. Now, everybody knows, at least common wisdom is, that post-polio syndrome is permanent. Well, maybe not. Patient history. This patient was at a course seminar in Germany. She was a 42-year-old female medical physician. She has no complaint of body pain, but she had complete loss of muscle mass in the left deltoid. And her history it was caused by a polio infection at the age of 2. So this is 40 years chronic. A physical exam, I confess, was observation only. I didn't do any specific muscle testing because, there's a big hole there where your deltoid should be. The central, medial, and lateral portions of the deltoid were all gone. So she sort of starts with the triceps back here. Shoulder range of motion was limited by loss of abduction and absence of all 3 areas of the deltoid. So you could see when she moved her shoulder, but the deficit was obvious. So a hypothesis was that the polio virus damaged the nerve and denervated the deltoid. So that's what we're working with, is right there. So we had the time waiver device, which is effectively a precision care, an auto care, and a custom care all in one machine run by a computer. The treatment was based on a hypothesis. Polio virus has affected the nerve, and that caused atrophy in the muscle. Polio doesn't affect the muscle, it affects the nerves. So if the polio virus is what we think is the problem, then we treat the nerve as a tissue, not the muscle. So to remove polio virus effects from the nerve, 23 is the frequency in the advance for poliomyelitis. It's also the frequency for mold, but that's another conversation because I'm not entirely sure how those two things are related. But we put the contacts at the neck and the elbow. And this is after 10 minutes. I'm going to flip back to that. So there's the dent where the deltoid used to be before we put the towels on. And you can see it starting to fill in from distal to proximal. The medial part of the deltoid started to fill in. This is in 10 minutes. Appears that 23 and 396 is time dependent. This is the muscle mass increasing after 20 minutes. Central portion of the deltoid improved. The lateral portion is filling in from the bottom up for reasons I don't understand. This is after 40 minutes. The posterior part of the deltoid is filling in. And there we go. Muscle mass was restored to normal, more or less, after about 16 minutes. 23 and 396, we now know is time dependent. It takes about 60 minutes. The muscle contracted, but it was not what you'd call an effective contraction. We could get it to twitch. We could get it to activate. So this was somebody's hand, not my hand, but this was somebody's hand on the deltoid and asking her to abduct her shoulder. That's in. So compare that to the first photograph where the deltoid was completely missing. So how would you treat this? Well, I'd treat her daily as needed to restore the muscle mass. And then after 1 week of daily treatment, I'd have 81 and 396 and 81 and 46, because that usually works on drop foot, kind of no matter how chronic it is. And then do general contraction exercises to activate and strengthen muscles. And then you'd have to use 81 and for increased secretions in the cerebellum, increased secretions in the sensory cortex, 92, and start to exercise it. Exercise as needed. So the next one is a 70-year-old female. Her friend was at the core seminar in London, and her friend said, I have a friend who's had ME, which is myoencephalitic encephalitis. It's chronic fatigue, 30 years chronic fatigue. Chronic fatigue is a very particular diagnosis. Turns out it was not chronic fatigue, and it was not incurable, because when she was 40 years old, they told her she had chronic fatigue, and it was permanent, learn to live with it. So let's do her story. So this was the history. Started when she was 40. Prior to age 40, she had 5 children, worked on a farm, had a difficult marriage, but she was really sturdy and hardworking a lot. Worked on the farm, cooked the meals, took in sewing, worked in the fields, worked a lot. At age 40, she had her 6th child. And there was about 6 years separating the 5th child from the 6th. So there was about 6 or 7 years between them. It was a normal birth, no forceps. Well, the pain started after the child's birth. She said, I had so much arm pain and arm weakness that I couldn't lift my child. The pain spread to the full body, and then she developed fatigue and sleep disturbance. So within a year, she was diagnosed with chronic fatigue syndrome and myalgic encephalomyelitis at age 40. Now, chronic fatigue is commonly known, ME is what they call it in the UK. It's commonly known as chronic fatigue syndrome, or ME, chronic fatigue, is a devastating multi-system disease that causes dysfunction in the neurological, immune, endocrine, and energy metabolism systems. The symptoms are post-exertional malaise, body pain, and fatigue, and it usually includes a symptom of swollen lymph nodes, episodic fevers, and a sore throat. So that's ME. That is a real diagnosis. It usually comes from some sort of viral or retroviral, but it is a differential diagnosis. It is different from fibromyalgia. So the diagnostic trail, it's in the history. That's what this section is about, is it's in the history. Was it a stroke? Was it polio? Is it ME? Patient presentation was she's healthy looking, cheerful, well-groomed, pleasant, non-smoking 70-year-old female. She was brought to be treated by her friend. She came in with a cane. Symptoms were body pain was a 7 or an 8 out of 10, but she was not overly dramatic about it, or there was no pain amplification symptoms. Poor sleep, don't sleep well, too much pain, poor digestion, bloating, occasional constipation, no history of sore throats, swollen lymph glands, or episodic fevers. So that symptom is not consistent with a diagnosis of chronic fatigue or ME. ME patients don't generally have body pain that's a 7 or an 8. So the person that diagnosed her when she was 40 was confused and just sort of missed it. Wouldn't have made much difference because both of them are incurable. So tell me about your life before age 40. So open-ended questions are a good way to get patient histories. Hardworking, married at age 20, 6 children between the age of 20 and 32. Well, maybe it was 6 and he was her 7th. Mentioned that she lived on a farm, raised 6 children, cooked meals for the farmhands, 3 meals a day, the kids and her husband. Money was so tight that after the kids were in bed, she took in sewing work, lots of lifting, lots of work, and then pregnancy at age 40 with a normal vaginal delivery. After the delivery, the arm pain started. That's the patient. That's her friend. Arm pain started within 3 months. She couldn't lift her child. Within 6 months, the body pain was severe. And when her seventh child was 7 years old, she finally left her husband, leaving behind her 6 children and taking the 7-year-old boy with her. Now, you have to think about what it's like for somebody that's 47 to leave behind her 6 children and going off into the unknown with a 7-year-old child with her. What does that make you think of asking? Why would she do that? That was what I thought of. Was the marriage difficult? Yes, it was very difficult. From the time we were married, we lived on this farm. I got pregnant pretty much every 1 to 2 years, 4 or 6 years. I guess she had 6 children. This was her 7th. Was your husband abusive? Yes, physically and emotionally. So when she bailed, when she finally bolted with the 7-year-old boy, her next youngest child was 13. So she basically saved herself and the boy and left the other 6 kids. She was still estranged from them. But when she left, she ended up living in a shelter and then moving in with her child, with the friend who brought her to the class to be treated. So it's quite a history. Physical exam, hyperactive patellar reflexes. Pain level was a 6 to a 7. She didn't take any pain meds. 40 and 10. I mean, it was simple. Positive, polarized positive, the contacts at the neck and the feet with the patient seated. I didn't want to try and get her on the table. We ran concussion in Vegas at her abdomen. Body pain was a 1 out of 10 at the end of an hour. And at the end of an hour, it was like, how does it feel to be out of pain? Weird. So I switched the contacts, switched the machine at her neck from 40 and 10 to 40 and 89. And 40 and 89 fixed that. And then we ran scarring in the spinal cord, scarring in the dura, because I was only going to be in England for another 2 days and I wouldn't have time to treat her again. So scarring in the cord, 13 and 10, 13 and 443. So she was seated and I had her bend her trunk forward, then back up to neutral, then side bend, side to side, rotate, then flexion again. And after about 20 to 25 minutes, she bent over and touched her toes for the first time in 30 years. So that was Thursday. And then I said, well, it's probably not going to last. We're going to be here till Sunday. Let me see you on Sunday. So she came in at the end of the class on Sunday, and she was pain-free until Sunday. She was running late as she ran to get to the hotel on time. And as she was running in these little shoes, as she was running, her pain went up to a 4 to a 5. So we did 40 and 10 with the patient seated, 81 and 10 with the patient seated to decrease spasticity and tightness in the legs, 40 and 89 to decrease the central sensitization, and then scarring 13 in the cord, 13 in the dura, and 13 in the nerves with rotation, flexion, side bending to get everything moving and gliding. And as far as I know, the last I heard, she is still pain-free. So that was yay. Isn't that a great picture? I just love that part. Okay. So those are the case reports, just to remind you to pay attention to the history. All right. So those were all the slides I had for this webinar. So I thought, well, what's important enough that I can put it in here and remind you about it? And we end up at the Vegas. Except for the post-polio patient, we treated concussion in Vegas on both of those pain patients. And I'm ending up treating concussion and vagus on just about everybody. The vagus is so important, we're going to talk about it frequently. So let's remember central sensitization, what that means. When you have stress of any kind, physical injury, infection, emotional stress, physical injury, any sort of stress, the midbrain, this part of the brain, actually it's probably the hippocampus combined with the thalamus and the amygdala. The midbrain, 89 in our world, remembers and puts in unconscious, subconscious, or rarely conscious memory early childhood and past injury, pain, infection, and stressful events, so you can predict and survive future events. The patient is unlikely to be aware of this sensitization or any of these memories. The visual stimuli, sounds, smells, even textures or furniture configurations can trigger the midbrain and set off a stress response reaction with no conscious memory of why it's happening or even what is happening. So the patient gets on the bus or the subway or train, and all of a sudden, pain in her shoulders goes up, pain at the base of her skull goes up, her stomach starts bothering her, and she assumes, for example, that she is EMF sensitive or that she's chemically sensitive. But you have to wonder, that smell thing, the organization of the furniture if you're in a furniture store, the smells, the sounds, the color of somebody's shirt, all of those things, all of those environmental observations can trigger the midbrain and set off a stress response reaction with no conscious memory of why it's happening or even what it's happening. Somebody on the plane or on the train is wearing a cologne that the man was wearing when he molested her when she was 5. Somebody on the plane, the train, the street, or in the meeting is wearing a shirt that's the same color as he wore, or that somebody wore when it was a stressful event. That's what the hippocampus gets paid to do. It triggers the midbrain and sets off a stress response reaction with no conscious memory of why it's happening or even what is happening. That's the mechanism of how a lot of digestive and sympathetic stress and even physical pain responses get triggered, and we can't figure out why, right? Because we have the same response to all stressors. The stress centers, the endocrine and nervous system reacts to all stress in more or less the same way. The stress centers in the midbrain suppress the vagus in order to increase your heart rate, suppress digestion, increase inflammation so you can survive. It is the same response whether you're being attacked by a tiger, you're in a fight with a colleague or a boss, you're in the middle of some sort of confrontation, a family, mom and dad are fighting, and the 2 kids are, oh my God. And these 2 little ones, Syria, Ukraine, any of the war zones in this world, U.S. detention centers at the border. So all of those are reacted to in exactly the same way. You have 30 minutes to live. What's going to keep you alive? What is most important? Well, you certainly don't need your digestion. So you decrease enzymes, decrease circulation, digestive enzymes, stomach acid, decrease the function of the gut, decrease circulation in the skin and the hands, increase circulation in the muscles. So the muscles feel congestion. The muscles in the upper trapezius and the neck get tight because of increased activity in the brainstem, in the medulla. Increase heart rate and blood pressure, increase cortisol to deal with inflammation. Well, if you increase cortisol, what happens to your gut? Increase immune system activation so you can survive the trauma and infection. It may not actually be trauma and infection, but the stress response is the same no matter what it is. If it's up long enough, it decreases thyroid stimulating hormone, peripheral thyroid conversion, growth hormone, follicle stimulating hormone, so you don't make as much progesterone. You get estrogen dominant, and your periods change, and luteinizing hormones change. So that reduces testosterone in males. They're all reduced because they're non-vital. You've only got 30 minutes to live. What is the point of digesting your food or making long-term repair hormones? The vagus gets in the way of survival during stress because the vagus slows the heart rate, increases digestion, and suppresses the immune system. The vagus is inhibited by the central stress response. So the midbrain turns the vagus off during stress so the heart rate can go up, the immune system can be very active, and the digestive system is turned off. The vagus gets in the way of survival. In a normal patient, once the infection is gone, the trauma is repaired, and the injuries heal, the afferent fibers of the vagus tell the brain that everything's fine, we're fine down here, it's all good. And then the vagus stops sending stressor information, the primitive stress centers calm down, the vagus comes back on, the immune system gets quiet, digestion and heart rate return to normal. In a normal patient, the efferent vagal stimulation gets normal. The heart rate slows down, the digestion, appetite, stomach acid, peristalsis, sphincter, and esophageal function all return to normal. The immune system is downregulated by the vagus. Inflammation and macrophage activity return to the normal quiet state. So the short version is the vagus activates good things and inhibits bad things. So the vagus increases cerebral blood flow, nitric oxide, brain-derived nerve growth factor, neurotrophism, which means your nerves recover, serotonin, norepinephrine, neurogenesis, right? Acetylcholine receptors. When the vagus inhibits, look at what the vagus inhibits. Glutamate, excitotoxicity. Glutamate is what makes you crazy. Glutamate is what creates inflammation in the nervous system. The vagus inhibits inflammation, TNF alpha, cell adhesion molecules. The vagus does all the good stuff and inhibits all the bad stuff. In a sensitized patient, though, that patient that had an early childhood surgery, had early childhood auto accident, had physical, emotional, or sexual abuse prior to the age of 7, the midbrain stress centers have a different and lower threshold, and they fire with much less external objective stress. So those stress centers stay on from normal life stresses and events. That colored shirt, that smell, the way the furniture is arranged, the textures, doesn't take a lot. And that keeps the vagus off or reduced. So what does that do in a sensitized patient when the vagus is off? The immune system remains unregulated and creates allergies, autoimmune conditions, and chronic inflammatory responses. The digestive system changes create leaky gut and further activate the immune system. The stress response system works well for short bursts, but if you're not dead in 30 minutes, it's pathological when it's prolonged, right? There are motor and sensory branches to the vagus. The vagus nerve accounts for 80 to 90% of the afferent nerves from the body to the CNS. The motor nerves of the vagus regulate all of the muscles involved in swallowing except for one. Look at the branches of the vagus. It's the longest nerve in the body. We think of it as regulating the heart, the esophagus, the gastrointestinal system, but it also regulates all the sphincters, and it has pain nerves. It has a sensory component that provides sensation from your bronchi, your chest, your lungs. Your lungs burn when you're coughing and you have pneumonia or bronchitis because the sensory nerves from the vagus tell your brain, ow, this is not good. Look at the vagus anatomy. It's everywhere. Look at these branches. That's the brachial plexus, but this is the vagus. Comes out of your brain, goes superior cervical cardiac branch of the vagus, goes down. One branch goes behind the esophagus, the other branch goes in front. You can find this. This is from Essential Anatomy. Who knew? I didn't know this. The vagus controls blood sugar by fibers that stop gluconeogenesis in the liver. I didn't know that. Vagus anatomy. Look at all the branches. The accessory nerve, there's the vagus. There's an auricular branch. There's a tympanic branch that goes to your ear, glossopharyngeal branches that regulate and it sort of joins in this ganglious nodosum for the pharyngeal and laryngeal branches. Look at this, sympathetics, parasympathetics, hypoglossal. It's tangled up in all of these nerves. So there's the vagal nuclei. In our world, that's 94. They're in the medulla. The vagus nerve is 109. So think about neck range of motion. Is the cerebellum going to allow you to move your neck full range if the vagus is adhered to the fascia? I don't think so. The cerebellum is very vigilant, especially about the vagus. What could lead to vagus adhesions? When I looked at this anatomy, I thought about people with neck surgery, people with open heart surgery. So look at these branches and think about what they do during open heart surgery. They slice that open, they pull it apart. Look at all the branches of the vagus that are everywhere in your chest. There's going to be adhesions. So heart surgery, whiplash injuries, neck surgery even. If you've ever had a sore throat or a sinus infection, the lymph glands get inflamed and the lymph glands and the lymphatic system run in between fascial layers along with the vagus, scarring in the vagus, scarring in the fascia, increases neck range of motion. I've done it 6 or 8 times and it never doesn't work. And as a matter of fact, since there is also a branch of the vagus that goes to the dura, did you know that? There's a branch of the vagus that goes around behind and innervates the dura. So those patients that have, those of you that do cranial sacral work, patients that have adhesions or whiplash injuries where that branch of the vagus gets adhered in between the fascia, you're going to have a constant strain on the dura caused by the vagus, caused by adhesions in the vagus. Who knew? So think about autoimmune disease. We did this last year. We're going to do it again next year. We're going to keep doing it again until everybody gets this at least straight in their head. What was going on in the patient's life in the year preceding the onset of the autoimmune condition? Early childhood trauma, home environment. How did you and your mom get along? Do you have any history of your home environment being violent? Were your parents fighting all the time? Were you physically, verbally, or sexually abused? Did you have a lot of infections as a child? That will turn off the vagus. Did you have a number of surgeries? Did you have a really bad auto accident when you were 5? So far, every autoimmune patient history has reported some dramatic increase in stress 3 to 18 months prior to the onset of the inflammatory autoimmune condition. So, is there any point in treating the immune system unless you quiet down the midbrain? No. How do you quiet down the midbrain? Mostly 40 and 89. So stress turns off the vagus. So when the stress is gone, you want to help reduce the activity of the stress centers. So 40 and 90, but 40 and 89, mostly in 40 and 94. Quiet down the stress response system and then turn the vagus back on. 94, trauma, 970, 124, increased secretions and vitality, all in the vagus. 124 is supposed to be time dependent, but I don't know if it is time dependent in the vagus. 81 and 109, increased secretions, suppresses the immune system, improves digestion, slows the heart rate, and re-regulates the immune system. Then you still need to repair the small intestine because all this time the vagus has been turned off. You've got SIBO, you've got IBS, you've got SIBO, you've got IBS. You have to repair the small intestine and then quiet the immune system directly. So I think this still applies even when the patient is on the biologicals. I don't see any harm in doing it. The biologicals are TNF alpha blockers. They are monoclonal antibodies, so they actually attack the TNF directly itself. Vitamin D and phosphatidylcholine support vitamin D to support immune system regulation, phosphatidylcholine to support acetylcholine, because the vagus uses acetylcholine as a neurotransmitter. Treat the affected tissues locally. Skin, you want to treat the scleroderma and psoriasis, the synovium in rheumatoid arthritis. You want to treat the thyroid in Hashimoto's. You want to treat the intestines in Crohn's disease, ulcerative colitis, autoimmune disease. Is there an adrenal component? By and large, can't put tissue back that's not there. So you're not going to make this hand look like that hand. But it does explain how dental infection turns off the vagus and can cause arthritis, anti-thyroid antibodies, or any autoimmune disease. The vagus is the connecting link. SIBO, vagus has to be involved. Gut bacteria are very pH dependent. The small intestine bacterial overgrowth can happen if the sphincters are working properly, if the small intestine is acid enough, and if food is digesting properly. What stimulates acid production? The vagus. What stimulates pancreatic enzyme production? The vagus. What stimulates gut motility and sphincter production? The vagus. So how would you treat SIBO? Well, concussion protocol. Treat the concussion protocol and treat the vagus at the same time. 40 and 89, 40 and 94, you might want to quiet down the sympathetics, maybe about 5 minutes each. But you also have to think about, is infection gone? Is the living environment safe? Is the trauma repaired or resolved? So if the patient has an active infection, mold or some sort of parasite, turning the vagus back on is going to reduce immune system activity. So that's not a great idea. 94, increased secretions in the parasympathetics. Be careful about turning on the parasympathetics if the SIBO is causing a lot of diarrhea. I'd put the contacts at the neck and abdomen. And then, how are you going to treat SIBO? Well, pus and pus encapsulated, fermentative and putrefactive toxin, 450 and 650. Trauma, paralysis, allergy reaction, inflammation, increased secretions and vitality in the pancreas and the stomach, the cecum, the small intestine, and the large colon, large bowel, maybe pre and probiotics and enzymes. The thing that always bothered me about SIBO is that people had it for years and they were on this horrible diet and they took all prebiotics, probiotics, and then 5 years later, they still have a diagnosis of SIBO. I think the missing piece in SIBO is treating the vagus. So that's where we live. This is just a reminder, in order to change lives and change the world, be sure to subscribe to the FSM practitioner list. It's $89 a year. The listing will include all your FSM courses, your clinical degree, a link to your practice website, your practice specialties. So if you have a special interest in fibromyalgia or SIBO or chronic fatigue, patients will find you. And FSM spends a fair amount of money to promote frequency-specific microcurrent, but it's designed to build patient awareness and support your practice as well. So those of you that are on the FSM practitioner list got a lot of phone calls after the Body Electric Summit and then after each of the webinars that I've done. All of that has built the seminar attendance, but it's also helped to build your practice. And I just want to remind you, I'm so excited. I finally got the advanced and pre-conference schedule done for 2020. Next year, we are moving the core seminars to 2 3-day modules. So there will be a pain and injury core that's taught by myself and Kim Pittis. And there is a 3-day neuro and visceral core that's taught by myself and Dr. David Musnick. We'll do 1 5-day course, 2 5-day course seminars in the US next year. The first one will be February 19th to 23rd. There's just no way to do the core in 4 days anymore. There's just too much information. So it's 5 days. FSM Sports, that 5 days is the 19th to the 23rd. FSM Sports is Kim Pittis. We take Monday off, and Kim teaches the sports seminar, which has just got great reviews and just great information. That's the 25th and 26th. I'm going to repeat the fibromyalgia workshop that the last time I did it was 2012. I'm going to update it, include the information about the vagus, and update the material on the other 5 types of fibromyalgia. John Sharkey is a world-renowned clinical anatomist, and he does fascia dissection and has worked with the plastination folks. And the title is Fascia and Biotensegrity Secrets for FSM Practitioners. Kevin is going to be emailing the schedule and posting the schedule on the website. So be sure and reserve your space for those 2 pre-conference workshops. And then the advanced is February 29th and March 1st. It's a leap year. And 2020 is going to be a leap year for us in more ways than one. And I'll tell you more about that in February. The advanced topics will include, I'll be doing the advanced the 2 mornings, but for people that have already taken the core, the advanced, David Hone attended the core seminar in Portland last year. And what he did was so good that I invited him to give this 3-hour workshop on personal energy sensitivity, protection and management, theory and practice of subtle energy for FSM practitioners. You have to have taken the advanced already to have that 3-hour block. We'll probably have David redo this course as a full day workshop at some point. Treating TBI and vestibular injuries with optometry. Bruce Wojciechowski is an optometrist and a fellow of the College of Optometry and Visual Development. And this is, everybody's coming to this. It's physical medicine, it's visceral medicine, it's what you didn't know you needed to know about saving lives with prism glasses. I don't even know how to tell you how transformational this work has been. And I have personal experience with it. So Dr. Bruce is the man. Don't miss it. The vagus, range of motion, pain, and autoimmunity. I'm going to do the vagus again. Turns out the vagus is the key to virtually everything we do. Visceral medicine track. Sleep is the crucial stable state. David Musnick is going to do 1 hour on sleep on the Sunday. Functional medicine and FSM strategies to help them sleep so they can recover from everything. Physical medicine track is FSM for CRPS, nerve pain, and maybe cervical spine. That's Jody Adams, treating CRPS and nerve pain when you didn't think you could. Jody ended up in the deep end of the pool this year and ended up treating 5 or 6 CRPS patients. So she's got a lot of advice on how to deal with that. Treating TBI and cognitive decline, David Musnick for 60 minutes on this. FSM and functional medicine strategies for treating traumatic brain injuries and cognitive decline. Kim Pittis is going to tell us about treating frozen shoulder, and she's got to be better at it than I am. So physical medicine, that's also on Sunday. Combined visceral and physical medicines track is the last thing on Sunday night, and it is an interdisciplinary panel discussion, and with time for Q&A, we will have at least 3 or 4 different disciplines represented in this workshop. And this came about because of what you asked for on the FSM practitioners page on Facebook. Be sure and look into that if you aren't already on it. Closing remarks on Sunday night, plans for FSM 2020 and beyond. Don't forget, on Friday night, the certified practitioners, the FSM practicum instructors, and the faculty will have a private dinner that is just for them up in that nifty upstairs area. And lunch the first day, we will do awards and recognition of the new FSM practitioners, and we will present the check for published paper. So this is it. Think about how the world changes because this lady got her life back. Her pain has been between a 6 and an 8 for 40 years, 30 years, and she's pain-free and will stay that way. So do good things, change lives, take care of yourself, and I'll talk to you next month.